Hello everyone. So again we are here with a new topic very common for all students to see. Now we have one patient who is having infective endocarditis, rather bacterial endocarditis, and we know bacterial endocarditis over the long time leads to clubbing. So this patient has very good clubbing, this patient has pallor, and this patient has cardiac failure. So that has led to pedal edema. So let us see all these three things together. So if you can just bring the camera closer. See, clubbing is nothing but bulbous enlargement of the nail beds. They are usually not like this that you might be seeing. I would just show them tangentially so that you can appreciate that the nail beds are bulbous. Clubbing occurs because of various causes, like in cardiac, as the patient is having bacterial endocarditis. It can be because of valvular abscess. It can be because of cyanotic congenital heart diseases. For respiratory causes, cyanosis can be because of bronchogenic carcinoma. Very late stages of tuberculosis, it can be because of chronic bronchitis. Even for GIT causes, bacterial the clubbing can be because of ulcerative colitis, Crohn's disease, GIT malignancies. So clubbing is a very common thing, but it is very helpful, that will help you lead towards that designated disease. So clubbing usually begins with disappearance of the nail bed angle. This is our nail bed, and we have a normal angle between the skin and the nail bed, which is called as a Lovey-Bonds angle, which is usually more than 160 degrees. As this finger or the nail bed starts becoming proliferated, this nail bed angle disappears. And when the patient tries to approximate both the fingers, see, you can see a diamond shaped gap between my nail beds. That is the normal phenomenon. But like in this patient where the nail bed is hypertrophied, if the patient tries to approximate the finger, this diamond shaped gap disappears. This is called as the Shamroth's test. Now there are various grades of clubbing. Like in grade 1 you just have the loss of the nail bed angle. In grade 2 you have a parrot beak appearance of the nail bed. In grade 3 you have drumstick appearance, and in grade 4 you have hypertrophic osteodystrophy, which is a painful swelling of the nail beds and other joints. So you should always see this clinical finding very carefully, because this will help you. What are the various mechanisms of clubbing? There are many postulated mechanisms, like hypoxia, like increased platelet derived growth factor, like increased ferritin, like opening of various AV fistula in the body that leads to vasodilatation, leading to proliferation of the tissue. So these are the postulated things that causes clubbing in a patient. So let us see closely the clubbing of this patient. So this is her nail beds. If you can see, all the fingers show clubbing, all the nail beds. If you compare it with my nail beds, obviously you can make the difference. Plus, if you can come vertically, if you see and compare the nail beds of the patients with me, there is clear cut pallor. The patient is pale because the patient has anemia with a decreased hemoglobin level. So, and if I try to do the Stamroth's test, see, from the top, if you can show, there is a disappearance of the obliteration of the nail bed angle. See, this is the Shamroth's test. You cannot see any gap between the approximated fingers here in this area. You cannot see that diamond shaped gap because this is obliterated. This is a positive Shamroth's test, which occurs in cases of clubbing. Plus we have seen pallor. See, this is pale. If you compare the palm of the patient with my palm, if you compare the nail bed of the patient with my nail bed, they are absolutely pale. So we can see it from the top. They are absolutely pale. This is pale. So I hope this clubbing and pallor is clear from this video. Now we go to the third component of this patient, which is pedal edema. Now pedal edema, we know it is a gameplay between the oncotic pressure and the hydrostatic pressure of the body, and there are various causes of pedal edema. We will not go into the detail. The common cause which the patient has is congestive cardiac failure. So let us see. Pedal edema, if you can show from the top. Pedal edema is usually seen or checked just above the medial malleolus, around 1 inch above the medial malleolus. You can either press the tissue with a single thumb, or you can press it with 3 fingers, so that you get valley between the hills, which will clearly delineate that the patient has edema. So this is the medial malleolus. Just above the medial malleolus, press hard for 15 seconds, and after that, when I will remove the fingers, it will show valley between the hills, which will prove that the patient has pedal edema. So if you can see, this is clear cut valley between the hills, which is showing that the patient has pedal edema. I can show you tangentially also, which has caused this dipping or depression in the skin tissue, leading to because of edema. So this is the area. One more area is on the shin with the thumb. You can also check it here, but the more accurate method is doing on just above the medial malleolus for pressing for 15 seconds. That will clearly, as you can see, clearly show the pedal edema. This is present, this is bilaterally symmetrical, and see, this is valley between the hills. So this is how you check for pedal edema. So I guess this was a short video, but it comprised of 3 main clinical signs of clubbing, pallor and pedal edema that we have kept reading in various books throughout our MBBS and post-graduation degrees. So I guess this video will help a lot of students and lot of doctors present out there, and I thank every one of you for your patient listening. Bye bye.